presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 5: Chief Complaint. A 55-year-old male presents to the emergency department with chest pain. History of present illness. Patient reports experiencing a sudden onset of chest pain that started 2 hours ago. The pain is described as heavy, squeezing sensation located in the center of his chest, radiating to his left arm. This is one of the important indications that suggests that the patient might be suffering from myocardial infarction, but let's not get too cheeky out here. Radiating to his left arm and jaw. The pain is accompanied by shortness of breath, nausea, and sweating. He denies any recent physical exertion or trauma. He is hypertensive, hyperlipidemia, and type 2 diabetes mellitus are in his past medical history. He is currently on amlodipine for blood pressure regulation, atorvastatin for statin therapy, and metformin for diabetes. He smokes 1 packet of cigarettes per day for 30 years, drinks alcohol occasionally, and is a truck driver by occupation. His father had myocardial infarction at the age of 60, and mother has type 2 diabetes. His blood pressure is 140 systolic, 90 diastolic, heart rate 95, respiratory rate 20, and temperature 37 degrees Celsius. Along with the SpO2 level which is 92% on room air. He has regular rhythm, no murmurs, and no jugular venous distension. He is clear to auscultation bilaterally on his respiratory region. He has a soft, non-tender abdomen and presents no organomegaly. He has no edema and the pulses are equal at both angles. Initial differential diagnosis: acute myocardial infarction, unstable angina, pulmonary embolism, aortic dissection, gastroesophageal reflux disease. Based on this presentation, what do you think is the most likely diagnosis and what further investigation steps would you consider? 5, 4, 3, 2, 1. If you're thinking acute myocardial infarction, then you might be on the right track, because due to the dermatomal association, the radiation towards the left arm accompanied by nausea and shortness of breath strongly suggests of acute myocardial infarction. So at the very beginning, we are going to assess the ABC, which is airway, breathing, and circulation. We have to check whether the patient is stable or not, first of all. Secondly, once we have checked out the stability, we'll try the patient to get off the pain. So we'll administer MONA. So MONA stands for morphine, oxygen, nitroglycerin, and aspirin. It's not actually administered in this order. First of all, we'll try to give nitroglycerin in the form of sublingual and IV to relieve pain. If the nitroglycerin is not working, we'll give them morphine, because morphine is a more potent painkiller. We'll give oxygen below 90%. So here in this case, we see that the oxygen is 96%, so oxygen therapy would not be immediately required. Aspirin would be given chewed to inhibit platelet aggregation. We'll obtain an ECG. Now the ECG should be obtained within 10 minutes so that we could identify any ST segment elevations or any other ischemic changes, which could suggest of the heart pathology. We perform blood tests, of course, for troponin I, troponin C, T, CKMB. These are the cardiac biomarkers which suggest towards myocardial injury. We'll do a complete blood count to check for anemia or any sort of white blood count raised. We'll for the basal metabolic panel to evaluate renal function and electrolytes. Why are we doing this here? So as to understand whether the heart is functioning properly or not, because heart releases antinatriuretic peptide. Now if that is not released, then there would be a fluid overload, because the ADH would be perfectly working, but that would somewhat be an over for the body. So because of the fluid overload, the body organs could shut down because they won't be able to work that properly. We'll do a coagulation profile by performing APTT, which is activated partial thromboplastin time. So this is checked out to see whether the intrinsic pathways and the common pathways of the coagulation cascade is working properly or not. Okay, when we are considering thrombolytic therapy, we'll do a chest X-ray so that we could see whether we could rule out aortic dissection or any other sort of pulmonary conditions. Okay, now there could be a lot of ECG findings we will discuss here. Two major ones which could occur. There could be an ST segment elevation, which is most likely in case of myocardial infarction, but myocardial infarction happens in two cases. There is an unstable angina and there is a stable angina. So when there is ST elevation myocardial infarction, in that case we would provide the person with PCI, which is primary percutaneous coronary intervention. Okay, now the limitation with this technique is that you have to do it within 90 minutes of the contact. Okay, then if due to any reason this is not available within the time period, we would lead them to a thrombolytic therapy, like giving them alteplase within 30 minutes of hospital arrival. Now there is another type of myocardial infarction, which is non-ST elevation myocardial infarction. Now this is unstable angina. This could lead to two things: unstable angina, myocardial infarction, as well as aortic dissection. So you have to be really sure what it might be. So in this case, because we have ruled out aortic dissection and we know it's myocardial infarction, this one we would start on with the antiplatelet therapy with aspirin and clopidogrel. We will start with anticoagulation by giving them unfractionated heparin or low molecular weight heparin, okay, with beta blockers like metoprolol, statins, which is already on currently, and of course we will suggest them for a cardiology consultation for post-acute management. We have like right now we have stabilized him and made him better, but to permanently cure it out, we'll give make them to permanently cure them out, we would present them in the ICU so that we could manage out any potential complications like arrhythmia. Okay, and we would also regulate their ongoing medication management, the ACE inhibitors, beta blockers and statins, along with the dual antiplatelet therapy. At the same time, while giving them these things which would change his physiology internally, we would also ask them to stop with their smoking habits and have a regular diet and exercise, and to try we will try to get their glycemic index under control. And of course we would ask them to regularly visit the clinic so that we could see if there are any risk factors which are not being modified time to time. Hope you guys like the case. Don't forget to take the screenshot, or you can always come back here to sum it up and let me know any suggestions. And thanks for watching. Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.